Hello, thank you for those kind words. Today I will be talking about childhood obesity and particularly trying to answer this question that I get always from parents that I see in the clinic. Should they be really worried about childhood obesity? Is it really something to be worried about, or is it just baby fat that magically disappears as the child grows older? So let's start off with the objectives for this talk. So these are the objectives that I would like to cover during this talk. Towards the end, I will be having a few case scenarios that I had seen in the clinic and also a few tips for both parents and providers that they can implement in their busy practice. So let's start off with the definition for obesity. So based on the Obesity Medicine Association, it is classified or defined as chronic relapsing multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces resulting in adverse metabolic, biochemical, and psychosocial health consequences. So what that means is obesity is not mere accumulation of fat and something that is a physical finding or physical appearance. It is a chronic illness that is affecting all organ systems and it has long-term complications. And we should consider it like any other chronic illness that we know, like diabetes, hypertension, and coronary artery disease. When we come to defining obesity among children, we have to use this growth chart, which is a favorite document by every pediatrician. So if we look at this growth chart, we can see those children with a BMI between the 85th and 95th percentile are classified as overweight, and those over 95th percentile are considered as obese. Moving forward, you can see the trend of childhood obesity over the last several decades. What you can notice is there has been a steady increase in childhood obesity across all age groups. This is a chart that shows us the trend or the percentage of childhood obesity in the United States between the age of 2 and 4 years. You can see that pretty much all the states have a minimum of 10% or more children in this group with obesity. And if we look at the age group 10 to 17, you can see that at least 6 states have more than 20% of their population with obesity. And it is the same case among high school students also, with Mississippi leading that chart with 23.4%. If you look at the overall statistics, 1 in 3 children in the US is either overweight or obese. And pediatric obesity in the US is close to 20%. So I would like you to kind of think about it and understand that 1 in 5 child in the US are obese. So that is how prevalent it is in the US. And it is not any different across the world. Whenever we talk about obesity, we definitely, before focusing in the management of, that includes lifestyle modification and physical activity, we need to rule out secondary causes of obesity. The big ones are as listed in this chart: monogenic disorders, syndromes like Prader-Willi and Bardet-Biedl syndrome, neurological causes, endocrine ones, specifically hypothyroidism, and less common Cushing syndrome, psychological aspects, drug-induced, and hypothalamic causes. If this is identified, it has to be treated before we do other interventions in managing obesity. Now let's look at obesity and life expectancy. So this is based on a New England Journal Medicine study where it showed that if the current rate of obesity are left unchecked, the current generation of American children will be the first in 2 centuries to have shorter life expectancy than their parents. Again, this is quite alarming and disturbing. The data shows that 1 million US adolescents are fulfilling the criteria for metabolic syndrome, and each half unit increase in BMI was associated with 50% increase in metabolic syndrome among overweight children and adolescents. 80% of the overweight adolescents ended up being obese adults. Again, so it emphasizes the importance of us pediatricians and parents intervening at an earlier phase, that is during this pediatric age group, so that we can prevent these children ending up as obese adults and having those comorbidities. As everyone is aware, obesity has comorbidities associating pretty much all organ systems. The big ones, as listed in this picture, are obstructive sleep apnea, stroke, heart disease, pancreatitis, fatty liver, and also several cancers. The big ones are breast cancer, uterus cancer, and colon cancer. Now, I would like to draw your attention towards a terminology called adiposity rebound. So if you look at the growth chart, you can see that the normal growth chart has a slight dip between the age 2 and 4 years, because that is the time when typically children tend to have significant increase in height, much more compared to the weight gain. So obviously there would be a dip in the BMI growth curves. But like this patient that I had seen in the clinic, you can see that this child did not have any adiposity rebound. And from the get-go, from 2 years of age, the BMI was skyrocketing. And these are the children who end up being severe obese. So as pediatricians, as providers, as parents, if we can identify these children and intervene at this early age, we are much more successful. And we would not have to struggle in improving their BMI when they reach at this phase. And also something to remember is, if you see a child with similar BMI, we would need to, even if they have some developmental delay, we would need to screen and rule out genetic syndromes. This is actually a study from NEJM from 2011. They had followed 6,000 individuals over 23 years. And what they found is those individuals who were overweight or obese during childhood, but were not obese as adults, had the same risk and outcomes as those who had normal BMI consistently from childhood to adulthood. Again, this tells us that if we see children in this high risk category, and if we make those right interventions early and normalize their BMI close to their adulthood, they have very much lower risk of developing comorbidities. And if we don't, what happens is these children who were overweight or obese tend to have 5 times more risk of developing type 2 diabetes, 3 times more risk of developing hypertension, and 2 times more risk of developing atherosclerosis. Let's look at the cost impact of obesity and comorbidities. So in the year of 2014, $1.42 trillion were spent on obesity and obesity-related comorbidities in healthcare. And the big ones are hypertension, diabetes mellitus, chronic back pain, and osteoarthritis. And the number is 1.72 trillion in 2016, which is 9.3% of the US GDP, and also much larger than the annual budget of several other countries. So it tells us how much of an impact obesity and related comorbidities has on the healthcare system and also on the economy. Let's focus on the management of obesity. So typically it is fivefold or 5 steps: diet, behavioral health, and physical activity, followed by pharmacotherapy and bariatric surgery. So today's talk, I would like to focus on diet, behavioral health, and physical activity. Pharmacotherapy and bariatric surgery are an entire different topic, maybe for a different talk on a different day. So when we start with diet, I would like to draw your attention towards the latest dietary guidelines that looked at the healthy eating index score among children and adolescents. So for those who are not familiar with healthy eating index score, it is an estimate of how balanced each one's diet or meal is. So 100 means they are perfect and following the guidelines to the T. So you can see that the age group 2 to 4 has a score of 61, and it slowly decreases as the age progresses, saying that the diet is not balanced as they get older. And again, if you recall, this was exactly how the trend for obesity was also seen across the nation. So older the children get, the more obese and overweight we saw the children to be. And then the typical recommended diet is the My Plate plan, where half of the plate should be fruits and vegetables, and the other half grains and proteins, along with dairy, and also limiting the sugary beverages, saturated fat, and sodium. So, as you all can recall as parents, the grains and the protein are not much of a struggle for our children to consume. So, it is the other half that they are constantly lacking. So typically when I see children in the clinic, we focus on incorporating more of this fruits and vegetables into their diet. So once you do that, what happens is automatically the grain and the protein percentage reduces. This is the latest 2020 dietary guidelines for Americans. And what it specifies is those children under the age of 6 months should be exclusively breastfed. And there are several studies backing that children who were exclusively breastfed are have had, has been immune from developing obesity in future. And those above the age of 6 months would be recommended to have a nutrient-dense complementary food that is rich in iron and zinc. And which is something that is very interesting that came out in this year's dietary guidelines is the focus on added sugar. So they had recommended that children over the age of 2 years should have only less than 10% of their total daily calories as added sugar. And those below the age of 2 years should not have any added sugar. Same thing with saturated fat. It was suggested to limit it to 10% of the daily calories for kids over the age of 2 years. And sodium was recommended to be limited to 2,300 milligrams per day. Now, a question that might come across your mind is, how do I figure out if there is added sugar? Or how do I know how much saturated fat? So it is all on the nutrition label. So if you pay close attention to the nutrition label on each food that you purchase, you would be able to make a better decision. So the first thing I want you to focus is the serving sizes and then the calories. Then there is a breakup of the macronutrients, and you could see the saturated fat, and here is the added sugar. So this would, spending that couple of extra few seconds in while doing grocery shopping would help you and your family a lot. And it will ensure that, you buy the right food into the house. Another one is water. So there has been several studies, but I'm quoting two of them over here. The first one is a randomized controlled trial that came out in 2008, where they showed that drinking water is associated with weight loss in overweight dieting women, independent of diet and activity. And the second one is the timing of the water consumption. Pre-meal water consumption has shown to be beneficial in weight loss. Now let's turn our focus to processed food. So this is actually two studies from Harvard. The first group was almost 100,000 adults were followed over 5 years. And what they found is 10% increase in the amount of ultra processed food people consumed was causing 12% increase in the risk of heart attack, stroke, and serious cardiovascular events. And the second study followed 20,000 people for over 10 years. And what they in this study, they saw that those who consumed 4 servings of ultra processed food had 62% higher risk of dying from all causes compared to those who ate only 2 servings per day. Again, the question is, like, how do I know, or how do you know if a food is ultra processed or not? Again, I would like to draw your attention towards the food label. So next to the nutrition label, there is the ingredients. So the question is, this is actually a spicy potato chips. Right? So why would a spicy potato chips require 16 to 20 lines of ingredients? And half of them, even a chemist cannot understand. So this tells you that, there is lots and lots of preservatives, chemicals, and colors added into these foods. So this would be a quick and easy way to identify if it's ultra processed or not. So rule of thumb is, if you can minimize the ingredients, the better it is. So I would say the max 3 to 5 lines would be acceptable. Another one is, when we are talking about any pediatric talk, it needs to have, you know, color. It cannot be, we have, because children are fascinated by color, and again, that is one way of drawing their attention. So I would recommend that we ask children to eat a rainbow every day. So what that means is, fruits and vegetables that kind of have similar color to a rainbow. So in that way, we are mostly ensuring that they have a well balanced uh, serving of fruit and vegetable in their diet. Going to the physical activity. For infants and toddlers, there are no set recommended physical activity, but again, it is recommended that they don't have any screen time. But for children and adolescents, it is recommended to get 60 minutes of moderate to vigorous physical activity daily. Now going to screen time. So this is actually a paper that was published in JAMA Pediatrics. And what they found is, for every 1 hour of screen time, 20 minutes of that was food commercials. So each hour the child spends on screen time, they are being exposed to this food commercials. And not surprising, the food commercials were mostly, the top ones were cereal, fast food, and snacks. So, is it surprising that our children are always fond of cereal and craving for fast food and always snacking? Because they are being constantly stimulated while watching the screen during the screen time about these food thoughts for food, thoughts about food, and that is what they are always thinking and craving. So this would be another reason why we want to limit the screen time, not only because it is sedentary, but also they are being constantly stimulated by these food commercials. Then, as I had mentioned earlier, whenever we talk about managing obesity, it cannot be without mentioning behavioral health problems, because there is a lot of behavioral health problems that are coexisting with children with obesity. So when we manage obesity, we should be closely working with behavioral health specialists in managing the underlying behavioral health problems. So the major ones that are existing among children with obesity are ADHD, depression, emotional eating, and anxiety. So we are only successful if we are able to manage these underlying behavioral health problems. Now, I would like to share a few clinical scenarios of some of the patients that I had seen in the clinic. So the first case is a 9-year-old with no past medical history or developmental delay. He has a family history of hypercholesteremia and diabetes. Physical exam is unremarkable, including his vitals. So you can see that this is the weight drop and this is the BMI drop. So the question is, what is the magic, as I would like to put it, that caused this weight drop? So basically what happened is he was seen by a dietitian who had prescribed a balanced meal plan. He had completely eliminated soda and juice. He started trying more vegetables and fruits in his diet. And then he was actively involved in football and basketball. So, what with all these interventions, he was able to lose 16% of his weight in 3 months. Again, I know this may not be, working for all children, but again, this kind of just shows that, those lifestyle modifications, physical activity will definitely work. Moving forward, case number two, this is actually a 14-year-old with whom I had seen who had history of migraine headaches and some learning difficulty. Family history was unremarkable, and exam and labs were normal. So you can see that there has been a dip in the weight and the BMI over here. The question is what helped, right? So mom is like, wasn't very quite, I mean, although we had discussed about lifestyle modifications, she wasn't very sure if the teenager had made those changes, maybe a little bit of a cut down in the soda and some activity, but again, mom was not quite impressed. But then we know there was an actual drop in the BMI. So the the magic behind that was we had switched his amitriptyline that took for his migraine to topiramate, because there are certain medications that are obesogenic, and again, that might also lead to this excess weight gain. He had lost with this change, along with some slight lifestyle modifications, almost 24 pounds, in that is 11% of his weight with this intervention. This chart shows us various medications and their effect on the BMI. So here you see that most of the anti-seizure and anti-migraine medications are associated with weight gain. And the next one is antipsychotic and antidepressants are also associated with weight gain. So if we can work with the behavioral specialist and the neurologist to find or switch the child to a more weight neutral or weight loss medication in the same category, that definitely would help with the management of their underlying obesity. Now, again, going back to the same patient, I'm sure at least some of you might have noticed, like I just focused on the drop, but what happened, what caused the steep spike in the BMI in that same child? So as I'm sure most of you guys have noticed, in this last 9 to 12 months, we are seeing this spike. And that is because of COVID. So the family actually had lost, his dad had lost his job. He was mostly online schooling, and they had to depend on the food pantry for groceries. So it is not an uncommon story, and we do see that very often uh, among our patients during this COVID pandemic. And again, this was a study from Italy, a questionnaire for 41 children during the lockdown period. And what they found is during this time frame, not surprisingly, there was significant increase in consumption of processed food, sugary drinks, and screen time, and significant decrease in sports activity. Again, this tells us that it is not surprising to see that rebound of BMI during this pandemic. Case number 4 is a 19-year-old female with type 1 diabetes for last 8 years. She also has hypothyroidism and is on levothyroxine. So I had seen her close to that 17-year age mark, and you can see that a drastic decrease in the BMI, almost to the point that she is now in the normal BMI. Her BMI is below the 85th percentile. Her BMI has normalized. Again, the question is what helped or what's the magic? So she did have lifestyle modifications. She was involved in more physical activity. She had watched the amount of carbohydrates in her diet. Previously, she had almost 100 to 150 grams of carbohydrates with each meal. So that was reduced to 50 to 75 grams and activity. But again, she was started on metformin 1000 milligram extended release medication, which had helped her cut down a lot of her food cravings and improvement in BMI. Um, she had lost almost 33 pounds, that is 20% weight loss, and BMI reduction of 5.8 kilogram per meter square. And some might think, because of the type 1 diabetes, but there can be improvement or loss of weight if there is poor uh, blood sugar control or blood sugar management. But in her case, she actually improved her HbA1c along with it, and last rate was 8.5%, starting from 12.3%. And this is actually the study that came out from in JAMA that looked at the randomized control trial that looked at the use of metformin among type 1 diabetic adolescents who were overweight or obese. It was conducted over a time frame of 26 weeks. Although they did not find any significant improvement in HbA1c at the end of the study, they were noticing among those individuals who took metformin, there was decreased insulin requirement and also improvement in BMI. So now let's talk about some tips that you might be able to implement at your house and during your busy clinics. The first one is, we talked about how to incorporate more vegetables into the diet. I know there are lots of kids who may not be liking vegetables and those picky eaters. So one way that I've found to be beneficial is pureeing these veggies in water or olive oil and mixing it into pretty much all the food that you prepare. Second one is a quick and easy, cheap intervention that you can reduce portion size would be consuming 2 cups of water before every meal and snack. And then thirdly, the grocery list. Because we are talking about childhood obesity and food consumption of the children, typically children only eat the food that is brought into the house by their parents, right? So if the parents can watch the type of food, looking at the food labels and ensuring that it is the right food and the healthy one that you want your children to eat, it can help a lot in changing or adapting or making those healthier changes in your in your child's food choices. Next is screen time and physical activity. So I know some children may not be very fond of being, walking or exercising, but then what you could negotiate with them by saying, add a screen time to it. I mean, watch your iPad or, listen to music or watch your favorite show while walking on the treadmill or, dancing or workout videos with your favorite music on. So that way, what happens is they are having fun and also being active. Next one is reward system. So that typically works among younger kids. So you can come up with, a non-edible prize or a present for adopting healthier lifestyle, like a sticker or a star, something like that. But again, if you try this for adolescents or teenagers, you might end up giving them, costly gift cards in order to get the same result. So I may not think about those options for teenagers, but maybe stick with this option for the little ones. And lastly, all these interventions has to be done at a family level. So all the family members should be involved in these interventions. So as I tell my patients, only the child cannot be having salad 3 times a day and rest of the family having donuts and burgers. So if we make these changes, it has to be incorporated at all among all family members. And there are strong studies showing that when the intervention is made as a whole family, there are better outcomes. And my personal experience, I've had several family members report that they themselves had lost 30 to 40 pounds, some of them, and also improved their A1C significantly when they joined their child in making these lifestyle modifications. And I think this is one of the biggest, I would say, um, benefits or perks of being a pediatrician, because we can make a change, a positive change, not only in our patients, but also among their family. These are some of the resources that I share with my patients for healthier meal plans and physical activity. And lastly, we all know one size does not fit all. So, I mean, things that I've discussed today may not work for all the patients or kids that you see in your practice or in the family. So, it needs to be an individualized care plan. And what I mean by that is, it is not what the physician recommends, it is not what the parent feels will work, but it is what the child likes and is willing to do. So it is the process of identifying things that the child likes and trying to tweak or modify it in such a way that they are it can be made into a healthier meal plan or a lifestyle. And I think that is the key to success in managing childhood obesity. So with that, I would like to conclude my talk. And again, I extend my thanks to the entire AKMG CME division for giving me this opportunity to talk about this topic. And I'll be open to answering any of your questions at the Q&A sessions. Thank you. Have a good evening.